Hi everybody, and welcome to our module on thalassemias. Before we talk about the thalassemias, let's just review anemias in general. In the module on microcytic anemias, I talked about how you can classify anemias using the MCV, and I talked about how there were a number of causes of so-called microcytic anemias where the MCV is lower than normal and less than 80. In the module on microcytic anemia, I talked about all of these causes except one, and that was the thalassemias, and we're going to focus on the thalassemias in this module now. Just a brief review of some key points about the microcytic anemias. All of the microcytic anemias, including thalassemias, are due to decreased hemoglobin content inside of red cells. When there's decreased hemoglobin, red blood cell precursors will undergo extra divisions, and therefore they will generate smaller than usual red cells, which have a low MCV. In addition to the low MCV, because there's less hemoglobin in the red cells will have a decreased mean corpuscular hemoglobin mass, and also a mean corpuscular hemoglobin concentration. And then finally, when there's decreased hemoglobin inside of red cells, the red cells will appear hypochromic on peripheral blood smear. This is an example of hypochromic red blood cells here. You can see that there's a large pale area in the center of the cell, much larger than what you see with normal red blood cells. Those cells are hypochromic, and they appear that way because they have decreased hemoglobin. Thalassemias are the result of decreased or absent production of globin chains. In alpha thalassemia, you have underproduction or absent production of the alpha globin chains. In beta thalassemia, it's the beta globin chains that are the problem. All hemoglobin molecules are made up of 4 globin chains, and there are 3 types of normally occurring hemoglobins that you can find in the serum. First is called hemoglobin A. This is the most prevalent type of hemoglobin in adults. It's 95% of hemoglobin. It's made up of 2 alpha chains and 2 beta chains. The less common type found in adults is called hemoglobin A2. This is usually less than 5% of our hemoglobin. It's made up of 2 alpha chains and 2 delta chains. And then finally, hemoglobin F is the fetal hemoglobin type. It's made up of 2 alpha chains and 2 gamma chains. So a key point here is that all hemoglobins have 2 alpha globin chains. It's the other chain that determines the type. If the other chain is betas, then it's hemoglobin A. If the other chain is deltas, it's hemoglobin A2. And if the other chain is gammas, it's hemoglobin F. And also note that the alpha chain is very important because it's a component of all 3 types of normally occurring hemoglobin. So if you have an alpha thalassemia and a problem with the alpha chains, it can affect all 3 types of hemoglobin. Beta globin chains, on the other hand, are only found in hemoglobin A, so people with beta thalassemia, as we will see, have a problem only producing hemoglobin A. And then finally, the delta and gamma chains are found in either hemoglobin A2 or hemoglobin F. You should be familiar with a very important diagnostic technique used in evaluating thalassemias and hemoglobin disorders, and that's called hemoglobin electrophoresis. In this disorder, you take a sample from a patient and you place it in a gel within an electrical charge. The different types of hemoglobin will move different distances in the electrical field, so this can determine how much hemoglobin A or A2 or hemoglobin F or abnormal hemoglobin like hemoglobin S is present in the patient's sample that you put on the gel. And it's used to diagnose hemoglobinopathies like thalassemia and also sickle cell disease. This is a picture of a hemoglobin electrophoresis on the screen here. These bands that are lighting up are different hemoglobins. They've moved different distances along this gel based on their characteristics and how they behave in the electrical field. And then based on standard samples of known quantities of different hemoglobins, you can determine, for example, that this band right here might represent one type of hemoglobin and this band right here might represent another. All of the thalassemia syndromes have a spectrum of severity. Some of them are called thalassemia minor. These syndromes are usually asymptomatic. Often the abnormal hemoglobin is identified on routine blood testing or a blood smear. In contrast, thalassemia major syndromes often have a severe loss of globin production. They can sometimes lead to patients who require lifelong transfusions for anemia, and sometimes patients who have an early death or sometimes even fetal death with severe thalassemia major syndromes. Let's start our discussion of specific types of thalassemia by talking about alpha thalassemia, which is a problem producing the alpha globin chains. You should know that there are 4 genes that code for alpha chains. 2 genes are found on each copy of chromosome 16. So a normal patient would look something like what I've shown in the top right corner of the screen here, with 2 healthy normal alpha globin genes on each copy of chromosome 16. We sometimes write this as alpha alpha / alpha alpha. Patients who have alpha thalassemia typically have gene deletions, and I've bolded the word gene deletions because this is an important distinction from beta thalassemia, which we'll talk about later, which commonly occurs due to mutations, not deletions. When one of the alpha genes is deleted, there is a decreased production of alpha chains, and this can lead to alpha thalassemia. So since we have 4 different alpha genes, you can imagine that there are 4 different circumstances in which you can be missing one or more of those genes. You can be missing just one of those genes as I've shown here. You can be missing 2 of them like I've shown here. You can be missing 3, or you can be missing all 4. And depending on the number that you are missing, this determines the severity of the alpha thalassemia. Patients who are missing just one alpha globin chain have what's called alpha thalassemia minima. These patients have normal red blood cells, they have no symptoms, they simply have the carrier state, and the biggest risk for them is that they can pass this gene on to one of their offspring, and if their offspring inherits another abnormal gene from their partner, then that offspring can have a more serious form of alpha thalassemia. Patients missing two alpha genes have what's known as alpha thalassemia minor. It's also sometimes called alpha thalassemia trait. These patients also have no symptoms. They sometimes have normal red blood cells, but other times they have a mild anemia with slightly decreased levels of the red blood cell indices. There are two variants of alpha thalassemia minor. One is called the cis variant and the other is called the trans variant. In the cis variant, there are two abnormal genes found on one chromosome. In the trans variant, there's one abnormal gene found on each chromosome. And for patients who have alpha thalassemia minor and have the cis variant, there's more risk that they will have an affected offspring, because if they pass this chromosome on to their offspring, that offspring will have two abnormal copies of the gene. A person with the trans variant can only pass one abnormal copy of the gene on to an offspring, and therefore there's less risk of a child with alpha thalassemia. If you have deletion of 3 alpha genes, you then have what's known as hemoglobin H disease. In this condition, there's very little production of alpha globin genes, and there's excess beta globin present. Beta globin is being produced, but it doesn't have alpha globin to combine with to form hemoglobin A. Therefore, there is an excessive amount of beta globin together, and the beta globin chains will bind together and form what's known as hemoglobin H, which is 4 beta chains together. This type of hemoglobin is abnormal. It's easily damaged. It also has a very high affinity for oxygen, 10 times the affinity of hemoglobin A. This makes it useless for oxygen delivery. It will bind oxygen but won't release it to tissues. And the hemoglobin H begins to form after birth. That's because there are no beta chains in hemoglobin F. Beta chains begin to be produced after birth, and when they are produced, they begin to combine together and form the hemoglobin H that occurs in this condition. Patients with this disorder have a hypochromic microcytic anemia, just like you would expect when they are unable to produce normal levels of hemoglobin. They will have a low MCV, also a low MCH and MCHC. An important feature of hemoglobin H disease to appreciate is that these patients have abnormal deformability of their red blood cells. This means that they will be cleared by the spleen. This will lead to a significant amount of extravascular hemolysis. So patients with this condition can have splenomegaly, they can have high bilirubin levels, and they can have an elevated LDH. And these features are all very important, especially when you're taking your boards. A microcytic anemia can look a lot like iron deficiency, but you should never see evidence of hemolysis in iron deficiency. If they tell you that the patient has splenomegaly, they are not describing a case of iron deficiency alone. There must be something else going on to lead to that extravascular hemolysis. Another feature of hemoglobin H disease is that hemoglobin H is easily oxidized, so there is a risk for intravascular hemolysis when these patients have oxidant stressors like infection or drugs. This is very similar to a glucose 6-phosphate dehydrogenase deficiency. Hemoglobin H disease is usually diagnosed with DNA testing. Electrophoresis can be used, but it's somewhat insensitive in this condition. That's because these patients produce some amounts of normal hemoglobins like A and A2. You can see hemoglobin H disease on electrophoresis, but you may not see much. It depends on how severe the condition is. For the purpose of your boards, anytime you see a description of hemoglobin H, you should know that they are talking about this form of alpha thalassemia. Some of the treatments that are used for hemoglobin H disease include splenectomy. If you remove the spleen, you eliminate the extravascular hemolysis, and this can improve the anemia, and then sometimes transfusions. And any patient who requires frequent transfusions for a chronic anemia is at risk for iron overload. As I've talked about in some of the other modules, we don't have a mechanism to excrete significant amounts of excess iron, so patients who receive repeated transfusions can develop an iron overload syndrome very similar to hemochromatosis. The final type of alpha thalassemia is called hemoglobin Bartz. This occurs when there's deletion of all 4 alpha globin genes. This is not compatible with life. These babies have no alpha globin. They cannot form hemoglobin F, which consists of alpha globin and gamma globins. As a result, gamma globin chains will bind together into a structure called hemoglobin Bartz. This consists of 4 gamma globin chains. It forms in utero. It's an abnormal type of hemoglobin, and it cannot release oxygen to tissues. It has a very high affinity for oxygen, 10 times greater than hemoglobin A. So oxygen will bind but not be delivered to tissues. As a result, a condition will develop in utero called hydrops fetalis. This is a syndrome that occurs when babies have severe anemia. They have massive total body anemia. One of the mechanisms is high output heart failure. You can see lots and lots of swelling on ultrasound of babies with this condition. And the fetus usually dies in utero, or the baby dies a few hours after it's born. Now let's talk about the beta thalassemias. These are conditions where there's decreased synthesis of beta globin chains. Beta globin chains come from 2 genes, not 4 like the alpha chains, and there's 1 gene on each copy of chromosome 11. Beta thalassemia is caused by mutations in the beta globin genes, not deletions like we saw with alpha thalassemia. And because this condition results from genetic mutations, there's a wide spectrum of disease depending on the specific mutation. So for example, if there's a mutation that results in a beta globin gene that makes no beta globins whatsoever, that's obviously a very severe mutation, and that will cause a severe disease. On the other hand, if a mutation leads to a beta globin gene that still produces a reasonable amount of beta globin chains, then the disorder will be much milder. For this reason, there's some confusing nomenclature around beta thalassemia. People will say beta sub-zero when they are referring to a beta gene that has no function, meaning it produces no beta globin genes. They'll sometimes write beta 1 when the gene has some function. People also often talk about beta thalassemia minor. This is when the patient has one mutated beta globin gene. This can range in severity depending on the specific mutation. They will say beta thalassemia major when both genes are mutated in a way that leads to a significant reduction in beta globin genes. So beta thalassemia minor occurs when patients are heterozygous and have one abnormal beta gene. This condition is also called beta thalassemia trait. And these patients have reduced production of beta globins, but they still make enough beta globins so that they usually remain asymptomatic. The way these patients are often identified is by detection of a mild anemia, a microcytic anemia, on routine blood work. The diagnosis is made by electrophoresis. You will see an increased amount of hemoglobin A2. Recall that hemoglobin A2 has 2 alpha chains and 2 delta chains. Importantly, it has no beta chains, so the amount of this hemoglobin will rise. Normal is less than 5%, and an increased hemoglobin A2 is a hallmark of beta thalassemia minor. That's something you definitely want to remember for your board exams. Beta thalassemia major, on the other hand, is when patients have 2 abnormal beta genes and the mutation results in a dramatic reduction in the production of beta globin chains. This is also sometimes called Cooley's anemia. These patients develop anemia beginning in the first year of life. The reason it happens in the first year of life is because that's when the hemoglobin F production begins to wane and they need those beta globin chains to make hemoglobin A. These patients have what's known as ineffective erythropoiesis. The alpha chains form tetramers, they precipitate, and the red blood cells become damaged, and the bone marrow fails to produce normal amounts of red blood cells. In addition, they have splenomegaly. They have abnormal deformity of the red blood cells, just like we talked about before in patients with alpha thalassemia, and therefore the spleen clears any abnormal red blood cells in the plasma. So for both of these reasons, they will have a severely reduced red blood cell count and a marked anemia. There are 4 important features of this disorder that I always remember so that I can recognize it. The first is a hypochromic microcytic anemia, just like you would expect in a patient with underproduction of normal hemoglobin. The second is marked abnormalities of red blood cell sizes and shapes. We'll talk about that in a minute. The third feature is erythroid hyperplasia, and the last feature is extramedullary hematopoiesis. Beta thalassemia major is famous for all the red blood cell abnormalities it causes on the peripheral blood smear. If you ever see a peripheral smear with lots and lots of different red cell abnormalities, you should think of this condition. It can cause most of the red cell abnormalities that you can think of. So first of all, it causes microcytosis. There are small red cells. There's also hypochromia from loss of hemoglobin. The patients who have this condition demonstrate anisocytosis on their peripheral smear. This is a wide variation in the sizes of the red cells. These patients can have an increased red blood cell distribution width compared to normal. There's also poikilocytosis. These are abnormal shapes of the red cells. And then 3 other findings you can see are basophilic stippling, nucleated red cells, and target cells. I'll talk about all these in the next few slides. So basophilic stippling occurs when there is residual RNA in the red cells. It's often seen in association with nucleated red blood cells, and you can see it in this form of thalassemia. It's also a characteristic finding in lead poisoning. These are some examples of basophilic stippling shown on the slide here. Target cells are red blood cells that have a circle that looks like a target in the center of the red cell. I'm circling a nice example of one right here. Normally the center of the red blood cell is pale, but the pale center of this red cell has a dark circle in the middle of it, and that's called a target cell. This occurs anytime there's an increase in the surface area to volume ratio of the cell. So for example, if there's extra cell membrane, you can get a target appearance. On the other hand, if you shrink the volume, you can then have an increased surface area to volume, and that can also produce target cells. So the reason they occur in beta thalassemia major is because there's decreased cell volume as a result of the abnormal hemoglobin. You can also sometimes see target cells for this reason in iron deficiency. You also classically see target cells when there's increased cell membranes. This occurs in liver disease. There's an increase in cholesterol in the membrane of red cells in liver disease, and that can lead to production of target cells. It's also a classic finding when there's splenic dysfunction or when the spleen has been removed. In this case, the spleen is not removing cells with excess membrane, so they can begin to circulate, and you can see target cells in the peripheral smear. The next characteristic feature of beta thalassemia major is erythroid hyperplasia. These patients have very high EPO levels, but they're not generating the normal response from the marrow. For this reason, there is a massive expansion of the bone marrow, and this is a consequence of severe anemia in beta major disease. For this reason, these patients, if they're left untreated, can develop abnormalities of the skull and facial bones as a result of the bone marrow working so hard to try and produce red cells. One of the findings is called a chipmunk facies. You can Google this and see examples of patients whose faces look like they are chipmunks because of the skull abnormalities. You can also see what's known as a crew cut appearance of the skull on X-ray. This is where the skull has little fine points of bone sticking out of it that look like a crew cut. In addition, children, if they're left untreated, can develop skeletal maturation problems where their bones don't grow normally. They can also have widening of the marrow spaces, and this can lead to osteoporosis. And then the last feature of beta thalassemia major is extramedullary hematopoiesis. This is hematopoiesis outside of the bone marrow. So your liver and spleen can produce red blood cells. They don't normally do this, but if the EPO level gets very high in the setting of a severe anemia, they can begin to produce red blood cells, and this is a consequence of severe anemia in beta major disease. So these patients can have hepatosplenomegaly because of extramedullary hematopoiesis, and this often generates nucleated red blood cells, which you can see in the peripheral smear. Patients with beta thalassemia major can get very sick if they develop an infection with parvovirus B19. This is a virus that infects red blood cell progenitors in the bone marrow, and it can cause what's known as an aplastic crisis, which is a very severe anemia. Patients who have beta thalassemia major are highly dependent on their bone marrow to produce whatever red cells it can. So if the bone marrow is knocked out by a B19 infection, they can become very sick. This also happens in patients with other severe anemias like sickle cell anemia. You can diagnose beta thalassemia major by using electrophoresis. There will be an increase in the hemoglobin forms that don't require beta chains. So you will see decreased or absent hemoglobin A because hemoglobin A requires 2 beta chains. You will see an increase in hemoglobin A2 because hemoglobin A2 has 2 alpha and 2 delta chains. You can also see an increase in hemoglobin F because hemoglobin F has 2 alpha chains and 2 gamma chains. The treatment for this condition is blood transfusions, and just like we talked about before with hemoglobin H disease, these patients are at risk for iron overload from the frequent transfusions. You will sometimes hear the term used beta thalassemia intermedia. This refers to beta thalassemia that is symptomatic but does not require frequent transfusions. These patients have a chronic hemolytic anemia, they have bone marrow expansion, they can have hepatosplenomegaly. Sometimes they are short of breath from the anemia and have other symptoms from the anemia, but the anemia is not so severe that they have to be transfused frequently. This is a clinical conundrum because transfusing these patients makes them feel better, but it places them at risk for iron overload. So a careful decision has to be made about how frequently and when to transfuse these patients because unlike beta thalassemia major, they are not dependent on the transfusions to survive. Let me mention malaria. Alpha and beta thalassemia are both protective versus malaria. There is less growth inside the red blood cells of the most severe form of malaria, malaria caused by Plasmodium falciparum. Keep in mind, patients who have thalassemias are just as likely to become infected as anyone else. However, when they do become infected, their syndrome is less severe because they have different types of hemoglobin inside of their red cells. Let me also mention a blood test called the red blood cell distribution width, or the RDW. This test is a measurement of the spectrum of red blood cell sizes. To appreciate this, let's look at the bottom left side of the screen. I've shown a plot of red blood cell size versus the number of cells. And in a normal patient, it's a relatively tight and narrow distribution width. That's because there's a relatively narrow distribution of sizes. In patients who have an iron deficiency anemia, the red blood cell distribution width can become very wide. That's because some of the cells are able to obtain normal amounts of iron and they will have a normal size. Other cells do not have access to iron, so they will be very, very small. This creates an increase in the number of sizes. This test is very useful in differentiating iron deficiency anemia from mild thalassemia. So patients with mild thalassemia do not have significant hemolysis and they may not be very sick. They may present simply with a microcytic anemia. It can look a lot like iron deficiency anemia. However, the red blood cell distribution width will be very wide in iron deficiency anemia. If you have a normal red cell distribution width, this makes iron deficiency very unlikely. The reason the red cell distribution width is not enlarged in mild thalassemia is because thalassemia is a genetic disorder, so all of the red cells are affected equally, and you maintain a relatively normal distribution of sizes. You don't get the wide distribution of sizes seen in iron deficiency anemia. This is only useful for differentiating iron deficiency anemia from mild thalassemia. If you have a major thalassemia, like beta thalassemia major, you can get all sorts of different shapes and sizes, and you can see a wide RDW. Let me leave you with a couple of key points about the thalassemias. So remember that thalassemias are microcytic hypochromic anemias, and anytime you're evaluating this type of anemia, you want to look for clues that there might be lead poisoning or sideroblastic anemia. These things are rare, and especially in a board question, there will usually be specific clues that these may be going on. Next, you want to think about problems with iron. So low iron can lead to iron deficiency or anemia of chronic disease. But if you're not dealing with either of these two things here, then you should suspect a thalassemia. And when this is the case, the hemoglobin electrophoresis can be very helpful. If it shows hemoglobin H or hemoglobin Bart's, then you know they're describing an alpha thalassemia. On the other hand, if it shows increased amounts of the hemoglobins that lack beta chains, like hemoglobin A2 and hemoglobin F, then they are describing a case of beta thalassemia. And that concludes our module on thalassemia.